Welcome back, students. We are getting into Unit 10 on the respiratory system right now. And this video is part 1, just talking about the main structures and main functions of those structures in the respiratory system. In the next section, part 2, we'll talk about kind of just respiratory events and regulation type things. So, what are some of the parts of the respiratory system, guys? Well, all the parts of the respiratory system, other than the alveoli, the little air sacs in the lungs that actually is where gas exchange happens, all the other structures are simply designed to get the air from outside into the alveoli or from the alveoli out, okay? And in addition to that, they need to condition the air, get it so it's going to be non-damaging to the alveoli, so they need to warm it up. You don't want it too cold. The alveoli are very thin membranes. One cell layer thick on the alveoli, one cell layer thick on the capillaries that are surrounding them, just two thin squamous cells between your blood and the outside air. So we want to warm that air before it gets down there. We want to moisten that air before it gets down there. If it's too dry, diffusion won't happen rapidly enough, and those tissues are going to break down as well. We need to filter out and catch foreign particles before they get in there. And all these structures up in our nose and our mouth and upper respiratory system help to do those things. And then in addition to that, we need to have some way to basically get air in there to get it to go in and out, and that's by changing the size of our chest cavity. Okay, if we can make the chest cavity internal space larger, it's going to generate a vacuum, bring things in. If we shrink that space, it's going to push air out. And so we'll talk about those things. So here we can see on this picture, we'll start up here with the nostrils or nares, behind which we have the nasal cavity. Goes back down. You can see here, you got the mouth. The oral cavity is the other place we can bring air in. And they share a tube, the nose and the mouth share a tube that both air and water can go down, right? The pharynx. This is why you can sometimes see videos of people being able to like suck in, spaghetti here and then blow it out and have it come out their nose, and they kind of like floss their nose out their mouth and out the nose kind of thing, because those are all connected. Okay? Then it gets down into the larynx and voice box region where we kind of have a switching station, which we'll talk about later to make sure the air goes the right direction. From there into the trachea, trachea into the bronchi, bronchi into varying branching bronchioles, and into the lungs themselves. We can also see here we got the ribs and intercostal muscles around the outside edge, and the diaphragm on the bottom, as well as the pleural membrane around the lungs, and all those play an important role. So what are the major functions of the respiratory system? We'll get into more detail on this later, but just to set the scene here for us. It's to supply the body with oxygen and dispose of carbon dioxide. That is its main job. All the other stuff it does is to make sure that that happens. It's about getting oxygen to your cells so they can carry out cellular respiration and getting rid of that waste product that's produced, which is carbon dioxide. Now, as far as respiration, not cellular respiration, but respiration as far as the system goes, there are 4 distinct processes that must happen. 1, pulmonary ventilation. Pulmonary refers to the lungs, and ventilation is simply moving air in and out of the lungs. That's one of the things that needs to happen. Number 2, external respiration. This is where we exchange the gases between the blood and the air in the lungs. So it's exchanging materials with the outside world, external respiration. Then we need transportation, which is what the circulatory system of the blood takes care of. Okay. And then we have internal respiration, which is the gas exchange within the body between the blood and the tissues. Oxygen from the blood to the tissues, carbon dioxide from the tissues to the blood. That's internal respiration. So let's start looking through the main structures, and we'll just work our way down the airway. The function of the nose, obviously, it's an airway for respiration. Its job is to moisten and warm the air, okay, and filtering and cleaning it of foreign matter. So we'll put them all up here. So moistening and warming the air, like we said before, the tissues in the alveoli and the lungs are very delicate. If it's too dry, diffusion isn't going to happen efficiently. Think a fish out of water. Once those gills dry out, it can't breathe anymore. Same thing with our lungs. And having our lungs inside our body is an adaptation that was necessary for organisms, animals to live on land. When we're in the water, we can have them external, gills. On land, we got to move those gills inside so we can keep them moist. Okay? And we need to warm the air as well, because if it's too cold, it's going to freeze things up down there, and it's not going to work, which is why if you're running in the cold in the winter when it's dry and cold out, you definitely want to be breathing through your nose, not your mouth. The nose has a lot more structures in it that help to moisten and warm the air. Mouth doesn't have much of that at all. Okay, and the nose also has filtering structures in there, which your mouth doesn't have. So breathing in through your nose is always better than your mouth. Breathing out doesn't matter either way. All right, moving in, we divide the nose into two main regions. The external nose, which includes the external nares or nostrils, and then where most of the stuff happens, the internal nasal cavity. So that nasal cavity is divided by a midline septum, just like the heart had a septum between the left and right ventricles. We have one in the nasal cavity, and you can see the bottom of it right here that separates your two nostrils. It opens into the nasopharynx, which is the pharynx behind the nose, up high in the head. And the ethmoid and sphenoid bones form the roof. We learned about those in the skeletal system. I'll put a picture here. And the floor is formed by the hard and soft palates. The hard palate you can feel. If you stick your finger in your mouth, right there, that's bone, okay, palatine bone. If you go further back, go far enough back, you'll feel it goes from being a hard bone into being a soft tissue. That is the soft palate. So here we can see on this picture, we got the nares and the external nose here. Then we go back into the nasal cavity. And you can see those three ridges in the nasal cavity, guys. Those are called nasal conchae. They serve a purpose we'll talk about in a minute. And on top, you can see the ethmoid and sphenoid bones. In addition, you can see how that bone right there, the ethmoid bone, is got a lot of holes in it. That allows some pretty direct connections between our olfactory sensors and the brain there. And then if we go back, we can see how that runs into the nasopharynx. And on the bottom, you can see the hard and soft palates we're talking about. All right, the olfactory mucosa, or the mucous membranes in the nose that deal with smell. Okay, they line the upper part of the nasal cavity, the superior part. We saw the ethmoid bone there where the connections go through, and they contain our smell receptors. And we're not going to get it too much into the sense of smell right now. If we've got time late in the year, we will get to that. But basically, smell receptors are chemical detectors. The receptors have different shapes, and if a chemical can fit in there, our brain will interpret that shape that fit that as a certain smell. And our sense of smell is pretty directly connected to our brain, I mean, right through the ethmoid bone. And it's one of our more primitive detection methods, and really brings back a lot of memories sometimes. You smell something, it'll bring back memories of something that happened a long time ago. The respiratory mucosa, that's the mucosa that's dealing with the respiratory functions of the nose, warming, moistening, filtering the air. So it lines the rest of it. It has glands that secrete mucus, and that mucus does a couple of different things. One, it obviously moistens the air because it's got a lot of moisture, and that gets dropped off to the air as the air passes through. And it's like fly paper to bacteria and viruses and dust that get into your nasal cavity and try to trap them before you can breathe them further into your lungs, hopefully. Okay. Now, if it traps them, how do we get rid of it? Either blowing our nose, but most of it actually drains down the back, down that nasopharynx, and down our throat, and eventually winds up in our stomach, which can kill most anything we breathe in. But yeah, you're probably swallowing on a normal day like 6 to 8 ounces, like nearly a cup of mucus on a normal day. When you're really producing a lot of it, or you got allergies, it's going to be more. Maybe that's why you're not so hungry when you have allergies. I don't know. All right, so inspired air. That's like Einstein was breathing, right? It was inspired. No, inspired air means you inspire as opposed to expire. Expire blows out, inspire breathe in. Okay. So that inspired air is warmed by a rich plexus of capillaries. That literally means there's just a big net of capillaries close to the surface of the nose. And just like we learned before, capillaries can act like a radiator for heat, right? We learned about this early in the year with temperature regulation and the cardiovascular system. Like if you get too cold, you close off the blood going to, your extremities, so you don't radiate out too much heat. But we got a lot of them in our nose, and that's to radiate heat to the air to warm it up. This is also why it's pretty easy to eat a bloody nose, because there's a lot of blood flow in there, and it's very close to the surface. So even if it gets too dry, it can crack and get into those. We have ciliated mucosal cells, which work to move that contaminated mucus out of the way. those three conchae, superior, medial, and inferior, that we looked at in that picture from before, they kind of stick out from the walls of the nasal cavity. And they do a couple things. One, they increase the mucosal surface area. So anytime you see multiple ridges of something, it's probably having to do with surface area and anatomy, right? So it increases the surface area, so there's more places for bacteria and viruses and dust to come in contact with the mucus to stick so it doesn't get further down. In addition, it enhances air turbulence. So rather than being a nice smooth stream of air going down into your lungs, it gets in there and those conchae cause it to swirl and spin and everything. Have you ever ridden one of those, I don't know what they call it, but they had it at the baseball fest fair, right? The big things everybody gets in and stands on the wall, then it spins and plasters you on the wall, right? Well, that's what's going on here. If we can get that air to spin, we throw the bacteria and viruses and dust out of the airstream, and they get stuck on the mucose on the walls and don't get into our lungs. So we want that air turbulence in there. Now, we do have some sensitive mucosa in there that triggers sneezing. If we have irritation particles in there, you get that sneeze reflex, which will cause you to forcefully expel that stuff that's getting into your airway because you don't want it into your lungs. So here we can see the nasal conchae right there, creating that turbulence and increased surface area. All right, so now we're going to go back into the sinuses. They're holes in the bone surrounding the nasal cavity. They, one, help to lighten the skull. You don't want bone where you don't need it. Structurally, it's not necessary, and you don't want to add extra weight if you don't need to. And it also gives another pocket for more surface area and things to warm and moisten the air. All right, now moving out of the nasal cavity back into the pharynx, that tube that connects the nose, the mouth, the esophagus, and trachea down, lower down. And it's skeletal muscle. Connects, like I said, the nasal cavity and the mouth on the top side, and the larynx in the esophagus on the bottom end. And it's a common passageway for both food and air. Divided into three regions, going top down, we have the nasopharynx, which is supposed to just carry air, right? That's the part right behind your nose, okay? Just air. Now, we all know that you can blow things up in there. If you've ever, laughed in the lunchroom while you're drinking milk as an elementary school, maybe some milk came out your nose, shows you all this is connected. So it can go the opposite way if you kind of override the swallowing and laughing things. Those signals get conflicted, and the nasopharynx doesn't close off to keep the food from going up. We'll look at that in the digestive system, but that nasopharynx is on the top. Oropharynx is oral, right? And that's behind the mouth. That is designed to have both air and food go through it. And the laryngopharynx, that's below the oropharynx, just above the larynx, laryngopharynx, and that's for both air and food as well. So the nasopharynx, I got a little ahead of myself before. Nasopharynx closes during swallowing to prevent food from going up into the nasal cavity. It kind of squeezes closed. It's not a tight squeeze, but it's enough to keep food from going up there normally. Your auditory tubes drain your inner ear into that area, which is sometimes if you get an ear infection, your throat will hurt, or if you get a throat infection, your ear will hurt because they're connected. It drains in there. Another thing that can happen sometimes if that auditory tubes get clogged up via the tonsils that are in there, swelling, the adenoids, then what's going to happen is that your inner ear can't drain that way, and then pressure is going to build up in your ear. If you have that happen enough and you can't relieve the pressure, doctors can put in ear tubes to drain, which is basically a tunnel through your eardrum, so it can drain out to the external. I had 2 sets of those when I was a kid because I had a lot of ear infections. They didn't put in a 3rd set because they were worried about too much scarring causing hearing damage at that point. But I do know people who've had more than 2 sets. Mentioned tonsils a little bit ago. The pharyngeal tonsils, otherwise known as adenoids, they're kind of high on the back wall of the nasopharynx. These are often removed if you have ear tubes because they're playing a role in blocking that auditory canal. These are the ones that are right next to the auditory canal. Mine were removed. The palatine tonsils, those are the ones when you go, you look back and you can see them on either side. Those are the ones you see, and they lie at the end of the soft palate, at the back end of the oropharynx. And then the lingual tonsils, if you have long enough fingers and you can curve them around your tongue, they're kind of just underneath and around behind your tongue as you go down in the oropharynx. Now, tonsils, remember from the immune system, they're basically immune system structures. They're designed to trap bacteria and viruses and get rid of them before it gets further in your body. They got little pits in them that, collect the bacteria, and then your immune system can try to fight them. But if your immune system doesn't fight the stuff that gets trapped there, then they get infected, and that's painful and cause problems. So if you have that happen too much, doctors may choose to have them removed, though they do serve a bit of a purpose in your immune system. All right, moving down into the voice box. Okay, it attaches to the hyoid bone and opens in the laryngeal pharynx superiorly. So here is a model of it. Here's the hyoid bone. Here's the larynx and the trachea down here. On the back side, this marker here is representing the esophagus. So you've got the esophagus going behind, and air can go down the front. So, like I said, continues to the trachea and on the anterior side, not the posterior side. The three functions of the larynx are to provide an airway, so it's a pathway for air to get into your lungs, to act as a switching mechanism to route air into your lungs and food into the esophagus, and to function in voice production. I've got a couple of videos here I'll show you that you can actually see the vocal cords in the larynx when people are singing and talking. So we can see them here in this model, and we can stretch them tighter with muscles, and the muscles, when they stretch them tighter, you'll get a higher pitch, and when they get looser, they'll produce a lower pitch. So we'll watch these videos real quick. So now the larynx itself is made out of cartilage, haline cartilage. So it's pretty tough, springy cartilage. It can hold the shape. And it's got rings in there to keep it from collapsing when you generate a vacuum to breathe in, which helps to keep the airway open. The epiglottis, this little trap door looking thing right here, it keeps food out of the larynx when you swallow. So when you swallow, this gets pushed down over the airway. So food comes down, hits that, and then bounces off it and goes down the esophagus. And you can feel that. It's kind of like a lever. This model doesn't show it real well, but there's a little lever point, and muscle will pull up on the front end of that lever and get the whole thing to kind of go like this. It'll pull up like on my knuckle. And you can feel that if you swallow. Put your hand right here. You can feel that upward motion that's happening when this comes down to keep the airway from having food go down it. Now, we've all had issues where we're talking and laughing or whatever while we're eating, and you get mixed signals from the brain. This will want to close to keep food from going in there, but it'll want to open because you're laughing, and that's when people choke. Stuff can get past that there because you're getting mixed signals on it. And we just cover that. All right, so here we can see the diagrams that I just showed you. All right, now moving further down into the trachea, which is this airway right here. You can feel it below. So this is your larynx and voice box up here. Here's your trachea down here. It's got these C-shaped rings in it. Okay, and the open area, as you can see in this picture here, is open towards the back where the esophagus is, where I've got this marker. Can you think of any reason why you wouldn't want the rings going all the way around? Now, they go part way around to make sure that the larynx doesn't collapse, or the trachea doesn't collapse when you take a deep, hard breath in. Think about like trying to drink a malt or a shake or some really thick one with a straw, and you suck hard, and all of a sudden the straw collapses, and then nothing goes through, right? We don't want that happening with the trachea, so we got this extra tough rings of cartilage around it to make sure that doesn't, but it doesn't go all the way to the back. Any thoughts on why? And it actually has to do with the fact that the esophagus is back there. If you're swallowing something really big, the esophagus is surrounded by a lot of hard muscle and the backbone back here, and it doesn't have a lot of room to expand. So if it needs to expand a lot, it can actually expand into the airway a little bit because those rings don't go all the way there. And that's why you can get some partial blockages of the airway without having food going down the airway. If for some reason we get stuck farther down in the esophagus, very rare, but it can happen, you could get a partial blockage there. All right, so now we move from the trachea down into the bronchi themselves, where it splits to go into each lung and the different lobes of those lungs. So by the time the air reaches the bronchus, it should be warm and cleansed of impurities as much as we can. It should be saturated with water vapor, so very moist. And then those bronchi are going to divide and divide and divide and divide, each supplying a different lobe of the lungs. And those air passages will undergo 23 orders of branching as they get to the lungs, which we'll see in this picture here. So we can see them coming down the larynx into the trachea. Trachea branches into two bronchi, which branch into tertiary, secondary, tertiary, quaternary bronchi, all the way down to little bitty bronchioles, which are the smallest vessels leading to the alveoli in the air sacs. Okay, so let's take a look at the gross anatomy of the lungs then. We can see in the picture over here and in the model I'm holding, these are pig lungs, so they're not quite the same shape as our human lungs, but they're similar in size. And they'd be sitting in me like this. These rounded parts are towards the backbone, and the backbone will be running right here. So here's our trachea. Hard to see here, but then branches into two bronchi, into the left and right lungs. And right here, we can see the cardiac notch where the heart would sit. Okay. So the apex is the narrow superior tip. The base is this part here, which would sit on the diaphragm. In the pig, it'd be sitting like this, and also sitting like this. The cardiac notch is here. We've got the left lung, is on the left side of the animal, the human, and the right lung over here, and they're separated into lobes. You saw this in your cat. It's not just one big structure. It's not super clear with the way these were preserved, but in humans, the left lung has two lobes, two divisions, and the right lung has three. On cats, you can add one more lobe to each side. It's 3 and 4, respectively. And those lobes, and breaking into different lobes, allows a fairly delicate structure like this to be able to move without ripping itself apart in our chest cavity. Okay. So the air, the respiratory membrane is the air-blood barrier. Before I get to that, just want to show you, here's a cross-section of a lung. And we can kind of see here, we can see the holes where the bronchi and bronchioles are running through. And this stuff that looks kind of like foam, that is, those are the alveoli, very tiny little sacs, pretty much microscopic, surrounded with little capillaries. And that is the membrane we're going to look at here, this where the air and the blood come very, very close. Okay. Blood flows on one side, air on the other. And then the gas exchange that happens there, guys, is just simple diffusion, going from high to low concentrations. All right, so the alveoli themselves, they are surrounded by some fine elastic fibers. And they contain open pores that allow one alveoli to get air or send air to another one. And that allows air pressure to equalize throughout the lungs, so you don't get too much pressure at the bottom and too little at the, or too much pressure at the top, too little in the bottom, and causing the lungs to rip. They're all equalized because of that. So here we can see them. So we can see each of these little sacs. Each sac is surrounded by a net of red capillaries, and that's so you have a ton of surface area, ton of it. If our lungs were just big empty sacs, you'd get what, maybe half a meter square of surface area where gas or oxygen and blood can come in close contact. With the alveoli structures, the surface area in an average lung is about the size of a tennis court if you were to lay it all out flat. A tennis court worth of air and blood contact. It's a lot more. You can see those little yellow fibers, those are elastic fibers. They help the lungs to return to their original shape when you're breathing out. And we got some smooth muscle that'll also help to contract those lungs and get them to move to their back to the original shape. I used to be able to get, little side story, I used to be able to get relatively fresh organs from Stradle's meat market before they closed, because they used to butcher whole animals and not just bring in the quarters and stuff to cut up. And when I could do that, I got, the fresh lungs from big pig. Okay. And so I thought it'd be fun to blow up the lungs. So I took everybody outside. We had them on a table. I stuck a tube in the trachea, clamped it shut, put it in my mouth, inflated the lungs by blowing into them, which is kind of the opposite of what happens. Usually lungs suck the air in, but I was blowing it in. And when you're done blowing, I went to take the tube out of my mouth so I could talk and, expound upon the wonders of the lung. I forgot about the elastic fibers around all the alveoli. So the lungs, even though I wasn't blowing anymore, the elastic fiber causes them to contract. Not as fast as they would if they were in the pig, but it was still enough to shoot air and lung juices and dead pig blood into my mouth and I pulled the tube away in my mouth and a big red streak along the side of my face, and then I just kept on teaching. It was nasty, but I didn't want to make a big deal out of it. It was gross. So don't forget that if you ever decide to blow into some fresh lungs. All right, so here we can see kind of the structure of an alveolus here. You can see that they're made up of simple squamous cells, one layer of flat cells, very thin, very little cytoplasm in there, so the oxygen doesn't have very far to go. And we can see on this picture on the right that the capillaries are also just one simple squamous cell thick. So the oxygen and carbon dioxide only has to pass through two very thin cells to get from the blood into the air or from the air into the blood. On the left, we can see where those capillaries are kind of networked all the way around. We can see the pores between the different alveoli. We can see some surfactant cells that help to, so if the lungs were to collapse, it's kind of an anti-stick formula, basically, so the lungs can open up again. And we can see some white blood cells and things like in there, macrophages, to get rid of any crap that gets in there that's not supposed to be in there. But we can see we got a lot of surface area where blood and air can come into close contact. Now, the pleural membrane, that's that sac that goes around the lung. Okay. The parietal pleura covers the thoracic wall and the superior face of the diaphragm, so it's the outer portion here. Okay. And then it's continuous around the heart in between the lungs. The visceral or pulmonary pleura is the part that's like tied up on the lungs. And then in between the two, we have pleural fluid. Okay. Pleural fluid. And now that fluid is like, it works to, have you ever had a glass in the summer with ice in it and it sweats, and then when you go to pick it up from the table, it kind of sticks a little bit? You either got to slide it sideways or you got to do a little more force to get it to come loose. Well, that's what that pleural fluid is doing in there. There are no tendons when your chest cavity expands and your diaphragm goes down. There's no tendons pulling your lungs apart. You don't see any tendons attached here, right? Pulling them out. They're completely separate. So how do you pull them open with the chest cavity and the diaphragm? Well, the way you do that is you put a fluid in between those two membranes. And so the membranes are attached, visceral to the lungs, the parietal to the inside of the ribs and the diaphragm. And when the ribs and diaphragm come out, there's the only thing that can happen is they're going to pull on this with that suction, like a suction cup, pulling these open, right? As long as this is completely filled with the pleural fluid, they're going to expand and contract with the lung, with the ribs and the diaphragm. Now, if you get a puncture in that, okay, say you get stabbed or you fall on something, it breaks through that parietal pleura, now air can get in there, okay, from the outside. So normally, the only way when your lungs expand for air to get into that chest cavity, when your chest cavity expands, it's got to go here, which means it's going to wind up in the lungs. But if you got a hole here, when your chest expands, some will go down here, but some can come in here. And now all of a sudden, you've got a pneumothorax. You've got air getting between the pleural membranes, and that means that when your chest cavity opens, eventually it can cause a collapsed lung. The lung won't pull out because air will just fill in that space. Okay, so you'll see that a lot on doctor shows and stuff like that, a pneumothorax, and then they got to get the air out, so they'll put a one-way valve in there so that they can get the air out of the lung and then get the lung reinflated through the right holes. So that pleural fluid, oh, I guess I jumped the gun. That pleural fluid is slippery fluid between the pleura. It's a friction reducer, and it cold welds or suction cups that stuff together so that it changes volume like we talked about. And I already told you what a pneumothorax is, a hole in the pleura, so you can't pull in the lungs, and you can't breathe in normally. And that will do it for this section of the notes, guys. Join me next time when we cover respiratory events and control. Have a good day.